You talked about testing too, and you had mentioned even earlier on about genetic testing and mutations that happen. Can you talk about when those are important, what to look for in the prostate cancer context?
Well, you hear about BRCA mutations with breast cancer. Not surprisingly, if you have a high risk of breast cancer in your family, that also translates to prostate cancer. They're both hormonal cancers, but particularly if you have BRCA mutations that run in families, we are able to treat patients that have those mutations with something that's called PARP inhibitors. And there's different kinds of PARP inhibitors that are in clinical trials right now. So you would have to check and see what's available for you. But oftentimes, we know that these mutations lead to more aggressive tumors, but sometimes it's kind of like hitting the jackpot because then you have access to an additional line of therapy that maybe other patients that don't have those mutations.
So is it general message that people, if they are diagnosed with prostate cancer, to just get the genetic testing, just to make sure that if anything progresses, they have more options? Or
I think it would be individualized. And so, I think that the urologist would discuss with the patient their family history and just kind of get a sense of how high their risk is. I don't believe that it's offered to everyone just because you want it. I'm not sure that you can necessarily get it. Or let me say that your insurance would cover it. You could always, I'm sure, pay for it out of pocket, but not everybody has that luxury. So, but if you have multiple family members that have prostate cancer, it's definitely something worth looking into.
absolutely. I was going to go into clinical trials and diversity in a little bit, but I feel that we're at a good point to sort of segue into it because you were talking about the PARP inhibitors. And I know that you guys, meaning City of Hope, just got funded by Pfizer to study one. And I'm not even going to try the name because I'm going to totally butcher it. So I'll leave it up to you, but it's very interesting. Can you tell us about this?
Yeah. I love working with on clinical trials because to me, clinical trials, how I try to explain it to people, it's like a VIP access to a cutting edge treatment. And so a lot of people can be afraid of clinical trials because, you might think that you're going to be a guinea pig. You have that mentality. There's a lot of mistrust in clinical trials in the Black community for sure. Um, you know, Number one, because of the Tuskegee syphilis experiment, that was just a trial gone completely wrong for 40 years. And so there's a lot of mistrust about clinical trials and who's funding it and who's behind it. And am I going to be a guinea pig? And am I going to get a placebo? A lot of people have an idea that they're going to get a placebo. When all actuality, if you participate in a clinical trial, you are either going to get standard of care, which would be what is offered in the clinic to anybody that would have your particular disease, but you also have the option where you may get the VIP treatment on top of the standard of care or in place of the standard of care. And it doesn't that the VIP drugs don't get to that stage, like that. It's like years and years and years in the making. So by the time it's to that point, we as scientists and physicians, feel very confident that this is going to work, which is why it's to the point where it's in a clinical trial. And there's different phases of clinical trials too. So there's, phase 1, phase 2, phase 3. Obviously, the later the phase, the more people have used that drug in that disease setting before. So you can decide, I don't want to do a phase 1 trial. I feel better with a phase 2 or a phase 3. So you have to keep that in mind as well. But with clinical trials, as you kind of touched on a little bit before, they're typically in the past have not included a lot of minority populations. So, Black, Latino, Asian, Native American for sure. And so it really does a disservice to everyone because you need to know how a drug would work in the context of different genetic variations. And so, one drug may work really well in one demographic and it might not work as well in another. And so we really try to accrue, which means kind of to recruit and enroll Black men in prostate cancer clinical trials, which makes sense because they're more likely to get the disease and die, younger. And so it's important to look at these new VIP cutting edge drugs and Black men that could really benefit from them. And as I mentioned before, some recent trials enrolled a lot of Black men, which we call race stratified clinical trials. What they found, there was a few studies. One was looking at hormone therapy, one was looking at chemotherapy, and one was looking at immunotherapy. And in all three of them, the Black men that participated in the trial had longer survival than men of other races and ethnicities. So when we looked at that, scientists of like me who do health disparities research, we were like, wow, like that's, so encouraging. So encouraging. So at City of Hope, we have a team. Certainly not one person can do it by themselves, so we have a team of scientists and physicians and clinical research nurses and statisticians where we come together and think about diseases and ways that we can help people who suffer the most from that disease. And so alongside of Dr. Rick Kittles, Dr. Tanya Dorf, who's the director of the genitourinary program there, and also Dr. ZJ Sun, he's another prostate cancer researcher. We designed a clinical trial that's going to use a PARP inhibitor called talazoparib. So that's the word that she didn't want to try to say. So it's a newer generation drug that's made by Pfizer. This trial is also sponsored by Prostate Cancer Foundation. And what it is we're going to be using PARP inhibitors in a racially diverse group of patients. So we are going to have a third of the patients be white men, a third of the patients be Black men, and a third of the patients be Asian American. And the reason we're looking at those groups is Asian American men, and the Asian population is very heterogeneous, so I just hate to throw it all into one, but many Asian American men actually do better with prostate cancer than white men. And then Black men do the worst. And so we want to see how is this drug, in different races, but we're not just picking races just to see, right? There has to be some sort of a scientific reason. And so the reasoning is there is an interplay at the cellular level between PARP and androgen receptor. And so androgen receptor has some variations that affects its function. Now, androgen and androgen receptor are crucial for prostate cancer cells to grow. So that's why if you get prostate cancer, one of the treatments is hormone therapy, because we want to block androgen, we want to block androgen receptor. And so there are racial differences due to genetics where different trinucleotide repeats that exist in androgen receptor, there's different lengths. So there's shorter repeat lengths, so there's longer repeat lengths. And Asian men, not just American, but Asian men tend to have longer repeats, and African American men tend to have shorter repeats. And so the repeat length we feel may affect the men's response to this PARP inhibitor with the talazoparib. As I said, this is going to be offered to patients who already have metastasis. So, they can do different drugs that are out there, but this PARP inhibitor could be something that's extra added to, let's say, their hormone therapy. And that's what we're looking at. We're looking at the talazoparib specifically with abiraterone acetate at this point in time.
I mean, that's exciting. I mean, like I'm a novice. I don't know any of the jargon. Didn't even want to attempt the name of that drug, but of that inhibitor. But so what, if I understand correctly, it's these differences and the length, these components that are different, that if you're able to study this, you can determine how this inhibitor in particular can better target specific patients based on, and in this case, it's race. It's the Black men, white men, Asian American men.
Yes, for sure. And then that's something that we could check in the future. We could look at their androgen receptor, look at your trinucleotide repeats, and we could say, look, you'll be a great candidate for this drug in the future, in the clinic, beyond clinical trials.
Does this drug target specifically the shorter?
No, so it's gonna target the same with everyone. We just think that the differences in the androgen receptor and the trinucleotide repeats within that receptor, within that gene, that there may be differences in response, and we don't know what to expect. It may work well in everyone. That's the hope. It could work well in everyone, and there may not even be a difference. But if there is a difference, we want to be able to tease that out.
And how long? I know you don't have a crystal ball, but how long until we have a better understanding of getting to an answer?
Yeah, so this is a 2-year study, but we assess the study. You don't just start the study and then just let it go and check at the end. You're constantly tracking your progress as it goes. So we should have a good idea, I would say, by the end of the year.
Okay, we're gonna check in. Now, you mentioned Tuskegee, the lack of trust, as you're talking about diversity in clinical trials and why it can be harder. I mean, you're doing recruiting now, or trying to accrue patients, and so what can be done differently? Is it just having more Black people and Black doctors recruit, because then there's that trust? I mean, I'm just curious how we try and do this shift here so that we can get more representation in the trials.
Yeah. Well, that to me is the most important part of it. So, in the past 20 years, there really has not been any increase in the amount of Black physicians that are accepted into medical school. That's the problem. It's not making it through medical school, it's getting the accepted into it part. And so, we know there was actually a study that came out of Oakland last year that showed that Black people who went to Black physicians, how much better their outcomes were and how much more of their diseases were addressed. We look at it in Black maternal death rates and infant mortality, and we know that just by the presence of a Black nurse or a Black physician in the room, that the mortality rates go down just by them being in the room. And so that is a lot to unpack, the reasons of why that is. But there is a trust factor when you have cultural competency in the room. And so, race doesn't have to match all the time, as long as your physician is culturally competent and sensitive, to different communication styles and cultural context, then it can work, just fine. But we know that there's still a lot of barriers for sure. And the patients feel that when they go into the office, they can feel it. And the bias goes both ways, so there's bias on the part of the patient, and then there's bias, we know, on the part of physicians as well. So first of all, increasing the number of minority physicians in general would help. But what we like to do, in addition to that, is to have a diverse team as well. So, and that's diversity in terms of race, but also gender, also age, also occupation. We have the physicians, we have the nurses, we have the scientists. And a lot of us that work within the Division of Health Equities at City of Hope have personal ties to how we even got into this. I got into this because of my dad. And so when I'm speaking to Black men who, and they're saying, oh, I feel fine, I don't have any symptoms. Well, really, because my dad didn't have any symptoms either, Oh, I don't know if I get that done, I'm not going to have a normal life. No, you'll have my dad had that and he's doing great, so we all that work on these teams have personal ties. And so it comes across as more genuine for sure. We're not just going to collect samples for research and just leave. Like, we are there to help the men. We do actual prostate cancer screening in the community, which is not the digital rectal exam. I know people freak out. We don't do that in the community, but we do the blood test. We provide the men their results. And then we offer follow-up care. And it's not just at City of Hope. So we partner with community clinics for men who may not have insurance or they're underinsured, just to make sure that they get that follow-up care, especially, if their numbers are low enough that we think it could be caught early. That's really the goal of everything that we do. But yeah, the mistrust, it's a real thing. And we try to tackle it that way. Another way to really increase minority enrollment in clinical trials is just to provide access in communities of color. Not everybody can travel to your main clinical trial center. And so I know at City of Hope, we're very fortunate to have community sites where, we have a center in Pasadena, or we have a center in Antelope Valley, or Santa Clarita, or Pomona. There's different locations where it makes it easier for patients to go from their neighborhood to a more close location to get treatment. So that helps as well. And then there's financial incentives as well, and that can be controversial. For sure. And, some of our trials offer them and some of them don't, but, a lot of times when you're a cancer patient, getting to clinical trials is expensive. You have to call off work, you and your caretaker. You might have to get lodging, you know, you might not live close by, or transportation costs. And so if a clinical trial can provide some sort of financial incentive to help overcome that, that can really open the door for a lot of people.
Yeah, I love that you're pointing all of that out. And I know telemedicine is not a cure-all by any stretch of the imagination. There are a lot of limitations, um, including with clinical trials. There are just certain appointments and things that have to happen face to face. But is that at least a little bit of a benefit, that there's more telemedicine? So maybe you can cut down on things that before might have been administrative, and people would be like, I can't do this, I can't participate, this would take too much time. But then you can kind of close that gap a little bit, just a little bit, with that kind of a tool.
Yeah, I think telemedicine definitely has its pros and cons. We've all learned during quarantine for sure. But so that translates to prostate cancer as well. If you don't live close and you have the technology and the app that you need, to communicate with your provider, then it definitely can give you access to perhaps more than you were exposed to before.
Access is that sort of key word. And since you were talking about it, Leanne, already, the community work that you do at City of Hope, and I know you oversee this program and really have delved into it. You'd already talked about it. You go to different parts of the community. You had mentioned like churches, fairs, community events. You do the free testing. And then can you talk a little bit more about the process? I know you talked about when you mail out the results and the follow-up. And then just sort of, wrap that by talking about the significance of getting out there into the community to have these touch points with people who otherwise would go completely unnoticed, unacknowledged, and, maybe never get a test in their life.
Yes. So yeah, that program, it's our community-based prostate cancer program that is directed by Dr. Rick Kittles. And I am lucky and blessed that he allows me to be the project coordinator for that. So I work under him to recruit licensed phlebotomists. We recruit volunteers. And let me tell you, it is not hard to recruit volunteers, because these events are like the highlight of our week. They're so fun. We get so much more out of these events than anything that we could give back. Like, we receive that in the energy of the individuals that we meet and we touch. So we go to these events, and first of all, we provide education. So let's say we're at a church. Usually the pastor will let us get on stage for 5 minutes and say, what are we here doing and why is this important? And we know in the literature that, unfortunately, the men who are at most at risk for aggressive prostate cancer don't think that they are. And so that's the first piece, is letting people know, like, listen, you are the high risk group. And then a lot of men are afraid of the digital rectal exam. So we let them know, listen, it's the PSA test now. You can get the DRE when you go to the doctor, but anymore since 2017, you lead with the PSA for sure. And so a lot of times they find that out, they're like, oh, okay, you don't have to do that, then I'll do the blood test. So that's the next part of it. And then also letting men know, most of the time with prostate cancer, you don't have any symptoms. And so, men are sitting, will be at, Taste of Soul or the Long Beach Jazz Festival, and men are sitting here with their drinks and their cigars, and I feel great. And it's like, you can feel great. You can have literally no symptoms. On the other hand, you might be urinating frequently at night, and don't freak out. That doesn't mean you have prostate cancer on the flip side either, but either way, you just want to stay on top of your prostate health. And so we go into the communities, we educate, we interact, we do the blood test, and then we follow up within 2 weeks is what we tell them. So we send every person an individualized letter. And by individualized, it's an official letter from City of Hope. It gives them their PSA level, but based on their race and based on their age, we translate to them what that means for them. So not everybody's letter is going to look the same, And so if they are a younger age, but they are showing like a 2.5 or a 3 PSA, we're like, you really want to follow up and get this double checked. And so we follow up within 2 weeks. If the men have very high levels of PSA, we will call as well to make sure they got that letter. We tend to follow up after a few weeks for everyone who has elevated PSA anyways, just to see what have you done with that. And you'd be shocked. A lot of men, they find out and they haven't told anybody and they're nervous to take the next step, so we kind of help them with that. And then we have social workers that help to navigate them getting to the next, follow-up person, whether it's at City of Hope. We would love to be able to offer the different treatments that we have, to everyone at City of Hope, but not everyone can travel that far, or maybe their insurance doesn't allow them to. So we partner with community clinics in the LA area where patients can go there as well.
It's such a great program. I mean, because otherwise it's this ignored, population that would be none the wiser, right, about the risks and their own health. I'm interested because when you get on the ground level like that, that's when you have conversations with people and can really understand the flavor of that lack of trust, for instance, or why they are so hesitant. The digital exam, rectal exam. It's just like that, they're like, what kind of digital are you talking about? So
Mhm.
what have you learned in speaking with some of these people that you didn't know before? I mean, anything just to help give you a better sense of what needs to shift? I mean, because whatever you learn, I think everyone who's watching this can learn from.
Yeah, I've learned how much people trust their doctor without knowing their personal risk, and they trust that their doctor knows their risk. And it's scary at how often it doesn't necessarily seem to be the case. And so I'll talk to men sometimes and they'll say, oh, I had that test done. And then I'll say, oh, so you went and got the blood test, and they'll say no, and then I find out they're talking about the colonoscopy. So that's one thing. A lot of times I hear, oh, I got all my blood work. My doctor does all my blood work every year. And so then I'll say, well, did they include that in your blood work? Because a lot of times it's not included. So a lot of times they're, checking your blood sugar and checking your enzymes, but they're not including the PSA. And so there's a lot of men, because now you have your medicine apps on your phone. So they'll say, no, I did it. My doctor ordered it. And they'll pull it up. And I say, if you don't mind, let's look and see, what was your PSA? And then it's not in there. And then they're just like, what? My doctor's not testing for this. So I would say that's the number one thing that I've learned, is how, it's endearing how a lot of people do trust their doctor. And then it is kind of sad to see sometimes that they're let down, but it's like, now you have the tools. Now you email your doctor, and next time you're in there, you let them know that you want to have this test. But actually, you don't have to, because we're going to do the test now, and we're going to give you a letter, and you can show your doctor. So
I love that the program goes really like step by step. It's not just like, here's the test, boom, and we're done with it. It helps really bring people through the process that can be so unfamiliar. My last question on this part of it is, I know you're so dedicated, Leanne, in this field, on the studies, like your eyes just light up when you're talking about everything. What do you hope will be the difference? Where will we be with prostate cancer, ideally in like 5 years, 10 years, that you think is plausible that we could actually get there?
I think we're so close. And when I got into this, when my dad was sick, I said, his doctor told him at that time, oh, you have a set amount of years. So he's past that amount of years, and he's doing well. We know he's not curable still, but I hope to change that. So when I got into this, I was like, I'm going to find a cure for my dad, which, a lot of people say that. And that's the goal of a lot of scientists. They have a loved one, and that's why they got into it in the first place. But I'm at a place at City of Hope where we have so many clinical trials, so many cutting edge treatments, and we're seeing patients that are really doing well. And I just feel like we're just like at the cusp of it. So I'm just like, Dad, hold on, just hold on. We're at the cusp of it. So I do think that it's around the corner. I don't think that it's something that's like decades away. I think it's sooner than we think. And I'm really hoping that's the case.